We have an exciting day for you all planned for all of us, and we are glad to see you. And we have Dr. Jennifer Grisham from UK Early Childhood Department. She's going to be talking to us about monitoring child development. It's a topic that lots of us have been eager to hear about in relation to children with NAS. Just a note that our next session is next week, not 2 weeks away, but 1 week away, because 2 weeks away is Election Day. We hope that everyone is out voting or has already voted. So we have Jennifer today. Next Tuesday, we will have Miriam Silman with trauma-informed interventions for families with young children. We'll have those materials for you in the next day or so. We'll have her materials ready for you to review. And then 3 weeks from then, we have Sharon. Now, Sharon, watch me on this one. Heseltine, is that right?
Yes, you got it. Good
practice. We'll have Sharon and Kim Hill. You're talking to us about the role of peers for families in recovery. So those are final 2 sessions after today. Today's agenda is much like any other day. Jason Joy is going to present a case for us. As you go to your breakout sessions, we suggest that you have a new person be your spokesperson, and then we'll come back together and share strategies together, and Jennifer will help walk us through the strategies that we've come up with. And we will close at 3:30. Just one change for this week. We had a couple of breakout groups that were fairly small. So today, Emily and Barb's group and my and Amanda's group are combining into one group. So you'll notice that if you're in those 2 groups, you're going to be in a different, larger grouping for today. Just some pointers for today. Please take care of your needs as we go. We appreciate everyone protecting the confidentiality of the clients who we talk about. We are recording the session and closed captioning the session. We do need case studies for our final 2 sessions. So if you have a case study amongst your caseload that relates to either trauma-informed interventions or the role of peers with families in recovery, please send us your case study. We would love to have it. The link is there for joining Slack, which is our discussion group, and it can be a discussion group by topics. Here's the link for where you can find all the session materials. If you have any trouble with your technology, simply contact Brandon and he will help you get back in. If you're bounced off of Zoom at any point, he will reassign you to a breakout group if that's where we are when you get bounced off. Sometimes folks get bounced off as that happens. We wanted to just point out that there's a neat resource that we were told about. It's through Facebook. There's a group called Neonatal Abstinence Syndrome Support. And it's got lots of great, frank discussions from moms and families about children with NAS. So we encourage you to check out that resource if you're interested. I now have the pleasure of introducing you to Jennifer Grisham from UK. Jennifer's professor in interdisciplinary early childhood at UK. She's also the faculty director for the early childhood lab there. Many of you probably know Dr. Grisham. She has been selected twice as the teacher who made a difference. She's a fabulous teacher, I can tell you that. She's dynamic and she knows her stuff. She's co-authored 2 books on blended practices in early childhood, and she's written a book on future planning for families. So those things really do relate to the topics that we're talking about with our series. She's got many state and federal grants. She's presented across the country and internationally. And really exciting, she has co-founded a children's home and preschool in Guatemala. So she's got really diverse interests. And at this point, I'm going to unshare my screen and we'll turn it over to Jennifer, to Dr. Grisham.
All right, are we good, Caroline?
Yes, we're seeing the slide. There you go, perfect.
All right, great. Well, I want to first of all thank Caroline and Christine and the rest of the team for inviting me to do this. I've been working in the field for a really long time, and I like to tell people, probably embarrass Caroline a little bit, that she and I were working in early intervention before it was really even called early intervention. So our careers have kind of mirrored each other throughout the years. And I don't consider myself an expert on this topic. However, I've worked with and around young children with a variety of needs for over 30 years now, and actually am been impacted by this topic personally, as we have a family member who has struggled with substance use issues and have seen the impact on her children. And so we've talked for many years about the impact of a variety of different substance abuse issues on the development of children. And so what I've tried to do in this presentation is to walk you through a little bit about what some of the main issues are that we see in children as they go through early development. You all had a nice lecture a few weeks ago on neonatal abstinence syndrome and kind of what we see with children when they're first born, when they're addicted to opioids. But this is really going to look at a little beyond that, and what will we expect in infancy and preschool, and up through even middle grades, and how that impacts that. And also talk a little bit about how we can monitor children's progress, because we know that these children are at risk for having developmental delays. And so it's important that we have some strategies in place for how to monitor their progress, to ensure that we capture any kind of delay that is occurring early on with that child, because we all know from years and years of research that early intervention is our best hope for trying to ameliorate some of the outcomes that we might see for children who are at risk for developmental delays. And so that's kind of what I hope to do today. I'm going to do just real quickly an overview of what some of the big issues are that we see in the development of young children who have been impacted by NAS, and then what type of assessment that we might do with those children. And then I'll go into detail around some specific outcomes that we're seeing from the research. Prematurity, of course, is something that the speaker talked about related to children who are born with NAS. And so there is an assessment of physical well-being that I'll mention that we've talked about before in these topics. Also want to talk about what some of the outcomes are related to the child's motor development, speech and language development, and cognitive development. And talk a bit about the neurodevelopmental assessments that might be used to screen for, to diagnose for, or to program for children who have developmental delays. I think there's a lot of concern with children who have NAS about behavior disorders. And so we're going to delve into that a little bit and look at what some of the primary issues are that we see with those children, and then also what are some assessments that we can use to try to determine those early on. I want to talk just a little bit about childhood trauma, which impacts the families of these children and impacts the children themselves because of the nature of the life in which they are living. And so I want to talk a little bit about family assessment and how to gather good information from families in order that they can identify goals for themselves as well as for their child. And then I want to talk about visual defects. I've worked for many, many years with children who have sensory impairments, and I think that sensory impairments are always kind of the last thing that people look at, and we overlook that a lot of times, yet it has an enormous impact on all areas of a child's development. And so I want to say a few words toward the end about visual defects that are often found in children who have NAS. I'm not going to spend much time on this because the speaker that talked about infancy and NAS talked about the Finnegan scales, which look at the assessment of well-being of children when they are first born and when they're oftentimes in the hospital or in the neonatal intensive care unit. But just for those of you who may were not there for that particular session, there is a commonly used screener that's looking at three major aspects of children when they are first born addicted, and those have to do with the central nervous system disturbances. And so, looking there at the tremors that we might see, and the increase in muscle tone. One of the themes that you're going to see as we talk about developmental outcomes of these children is the abnormal motor reflexes that these children oftentimes demonstrate. And so we start seeing that very early on after they're born. Then we have the metabolic and vasomotor respiratory disturbances, the sweating and the nasal flaring that's sometimes evidence. And that is monitored several times again while the children are in the NICU or in the hospital. And then, of course, the gastrointestinal disturbances, the poor feeding, and the loose stools that we'll see. And I encourage you that if you didn't hear the lecture on NAS, the overview of NAS, that you go back and listen to that, where these particular outcomes are described in much greater detail, and what the implications are, and how a treatment with the mom can assist in helping children overcome some of these things early on. So I want to talk for just a few minutes about the type of delays that we see cognitively with children's motor impairments, and also with their social communication needs. So when it comes to cognitive development, you'll notice here that there have been meta-analyses that have now been done looking at children who had prenatal exposure to opioids and comparing them to a control group. And in one study, what they found is a significant difference in neurocognitive development with children who were prenatally exposed to drugs. So, in other words, children who have been prenatally exposed, in a comparison to a control group, they have a significantly lower cognitive outcome on a standardized norm reference test. And when I was reading through this, it reminded me of a study that we did many years ago in Kentucky. Well, it's probably been about 6 or 7 years ago now, where we looked at children from high risk, low income areas of Kentucky, and looked at developmental outcomes of those children, and found that in our own state, that in the sample that we had of children that were between the ages of 18 months and 36 months, that those children were functioning on average 1 standard deviation below in all areas of development. And of course, we probably weren't as cognizant at the time of the impact of opioids on children's development. But I have to think now, in looking at some of those communities, that may have not had an impact. While this is national data that we're looking at here, my suggestion is that it's likely that we would see similar outcomes to the children if we were to do a study in Kentucky. There was also a follow-up study that was done with 149 children where they administer the Bailey scales, which is a common standardized norm referenced assessment where we compare children of the same age to children who have a diagnosed or a suspected problem. And with those children, children in the 18 to 24 month age range that were in the methadone group had significantly lower cognitive scores compared to other groups. And so, you know, in education, we talk a lot of the time about the achievement gap. And that achievement gap is oftentimes discussed in great detail when children are in about 3rd grade, when standardized testing occurs in education. But what we're seeing in these studies of infants and toddlers as young as, 18 months of age, is that we're seeing very clear gaps in development of these children at a very, very young age. And so this is something that we need to take notice of, and should be another part of the rationale for why it is so important that we provide intervention with these children at a very young age. When it comes to motor development, we also see some abnormal motor patterns that are occurring with these children. There are atypical motor patterns during the first year of life, such as writhing and fidgeting movements. And you'll notice in the bullet below that it talked about children having, as they're going through that withdrawal process, that they're experiencing hypertonia, and which means that they have very high muscle tone. And that high muscle tone, of course, can lead to abnormal movement patterns and can also lead to uh, problems that look very similar to children who have cerebral palsy. And so these children are at risk for motor delays, throughout their life as a result of what they experience early on. There's also an increased occurrence of torticollis, which is a shortening of the neck muscle on one side of the children. This may occur prenatally or postnatally with the child. And this again can result in poor motor pattern quality for those children, and is something that requires intervention for them. And it also can result in a higher incidence of atypical neurologic examinations. And so when infants are very young, we're looking for reflexes that for some children will go away when those children reach a certain milestone. But for some of the children that we're working with who have NAS, those abnormal reflexes, one example is the asymmetrical tonic neck reflex, or sometimes referred to as like the fencer pose, where the child's head turns when the child's arm goes out. Those types of reflexes, which would disappear on a neurologically sound child, might still be present in children who have been affected by NAS. Another one that is sometimes discussed is the Moro reflex, or the fright response that children have that will be inhibited after a period of time in children who are neurotypically developing. But for children who have been exposed to opioids in utero, that particular reflex may continue as children get to be a little bit older. And so motor delays is another thing that we're looking at with these children. The speech and language research is very interesting to me. In this particular meta-analysis, what they did is that they compared children who were children with NAS and a high-risk control group. And you can see below what is defined as the high-risk control group. So in many cases, the children in the high-risk control group were also children that had exposure to a variety of different substances. And so, but as it turns out in this particular case, we see very similar patterns of language development at the 1 and 5 year follow-up study, where the children are experiencing, the percentage of children that have language delays is similar to those of children that do not have neonatal abstinence syndrome. But then at the 10-year mark, we see that children who have NAS have double the language delay of children who do not have NAS. And so what this suggests is that the children who have NAS specifically, not just other at-risk populations of children, but the children who have NAS specifically have very unusual patterns of language development. And of course, for those of you who are speech and language therapists who are out there, we all know the relationship between speech and language development and children's later literacy outcomes. And so being aware that, these children are going to show evidence early on, but that, that pattern of delay is going to continue up until the later elementary age or up into the middle grades. And so we have to stay vigilant in monitoring children's language development. And I assume that most of the group that's here would be aware of the studies that looked at the differences between children who are from low and middle and high income homes, and the impact that just being in that kind of environment can have on children's language development. And I'm referring specifically to the Hart and Risley study that's rather dated at this point, but is still looked at as being a seminal study to examine the impact of a child's uh, cultural or their background on their language development. And so it occurs to me when I read and look at the language outcomes of these children that we are layering on top of the neonatal abstinence syndrome or other type of experiences. We're oftentimes layering on top of that poverty, which is also a very strong predictor of negative language outcomes for children. And so because of that, it makes the importance of adhering to and addressing children's speech and language development very, very important from a young age, and for us to stay vigilant in looking at that as children get older. When it comes to development and developmental delays in language and literacy, in language, in cognitive development, and in motor development, I've listed for you here 3 categories of assessments that can be helpful in monitoring whether or not children are making progress in those areas of development. And I'll start with the screener, which is a screener that I know there are many of you all that work in early intervention that are participating in this. And it is the screener that's used predominantly in early intervention. And just simply to answer the question, is there additional testing that is needed? And I think that what you see from those developmental studies that I just showed you is that these developmental problems can show up in a child's life at various points. And so even if a child is not qualifying for early intervention, tracking a child's development through using some kind of high quality developmental screener is something that is recommended. And Ages as Stages is one of the most widely used screeners in the entire world, not just in Kentucky, not just in the United States, but in the entire world, and has been translated into just about every language that you can imagine. And so that particular screener is one that, regardless of what kind of program that you're working in, whether you're having direct working directly with children through early intervention, or you're working with families, trying to have something that monitors and follows children's progress is something that's really critical. Diagnostically, in the research, in the reading list that I provided for you all at this end of this presentation, the diagnostic tool that's used primarily with children who have NAS is the Bailey Scales of Infant and Toddler Development. It is one of the few tests that's out there diagnostically that can be used with children who are that are premature. And so that's one of the primary reasons that it would be used. In Kentucky for program planning and progress monitoring. And so if we're just interested in seeing whether or not children are making a general progress, not comparing them to other children, but just looking at their progress over time and comparing them to themselves as they they're 6 months old and 12 months old. There are 3 primary program planning tools that we use in Kentucky: the Assessment, Evaluation, and Programming System, AEPS, which is a birth to 6 assessment that's criterion reference, that has activities that go along with it that you can implement or support families in implementing in their home. Similar to that is the Carolina curriculum, which has a birth to 3, an infant, toddler, and a preschool version to it. That also has activities for how to support families to support their child's development in home situations. And then finally, the Hawaii Early Learning Profile, which is a very detailed criterion referenced assessment that has help at home activities that were specifically designed for home visitors to work with families in the home that are written from the child's point of view so that they're easy for the family to understand. And so this is just a list of the different types of tool you can use. A bit more information I've provided in here about ages and stages. I think most of you are familiar with this, but just as a reminder, it goes from birth all the way up to 5.5 years. I think there's actually an ASQ4 that's in the research edition that's coming out soon. It is completed by parents in 2 to 3 minutes. And so you score the child every 2 months. And so again, for those of you who are working in a family type program, this would be an ideal system for you to monitor and make sure that the child is on target. It has an online option to it. And in fact, it's my understanding that there are some pediatricians in the Central Kentucky area that actually use this particular tool at well baby checks, which is really ideal. It has the largest norm population for any screener ever, over 12,000 children. It's available in English and Spanish and French. And like Christine was talking about the CDC materials, the ASQ has also been translated into Vietnamese and Arabic and just about any language that you can think of. And it also includes some learning activities, which is a new component to the screening tool, again, to help families support their child's development, which is always very, very important. So I'll move on now very quickly to challenging behavior. There are a lot, this is oftentimes, I noticed in the case study for today, this is the primary concern of the family and of whoever's working with the child has to do with the child's challenging behaviors. And so we start to see behavioral differences. I don't want to say that an infant has challenging behavior because I don't think that's appropriate. But they do have behavioral differences from children who do not have NAS, and so we start to see that they show a negative affect in terms of how they interact with the adults that they're interacting with. They have a very hard time regulating and self-regulating, and they need a lot of support to be able to regulate. And they also are more likely to have increased sensory seeking behaviors where they are seeking out, whether it's oral or vestibular or other types of sensory interactions. So as children get to be a little bit older, we start to see the types of things that are more disturbing for some of us. And so in one study, there was 87 children that were examined in a NICU follow-up clinic, and 26% of the families reported significant behavioral or sleep difficulties. And so you're seeing some of the same things related to infancy, where children are having difficulty with sensory integration, they're having difficulty with sleep, they're having difficulty with hyperactivity and also with tantrums. And I think one of the important things to remember here is something that we talk all the time about in early childhood, which is the interaction between developmental areas. And so if children, for example, are having trouble in the cognitive area, in problem solving, let's say, for example, then they're gonna have difficulty trying to self-regulate because they don't have the problem solving schemes to figure out how to regulate themselves. Or if a child is having language delays, then that child is going to have difficulty, more likely is going to perhaps have tantrums because they lack the ability to know how to express their displeasure, or to express their confusion, or to express their frustration because of the language delays. And so we want to remember that some of these delays that in social emotional, I prefer to call it these social emotional delays, are result from delays in other areas of development. Um, in looking at a review of some other articles about neurobehavioral consequences of opioid exposure, we see again that there are 5 areas that were analyzed, um, and all that the children who were exposed to that were have NAS have poor developmental trends in all of those domains, and so that speaks to what I just talked about related to the interaction of all of those things. Children born to mothers um, who completed a neurobehavioral testing indicated elevated levels of hyperactivity, impulsivity, and attention problems. And so we are oftentimes seeing children who are just really struggling to kind of keep it all together, is the way that I describe it, and have difficulty, um, you know, with change, have difficulty with, you know, all of the chaos sometimes that many of them are living in, that exacerbates these problems that they already have a propensity for. And so the tool that is used a lot out there to look at the social emotional health of children is the Ages and Stages Social Emotional. And this looks at those areas of social emotional health that we often find to be problematic for children with NAS. And so it looks at self-regulation and compliance. It looks at the communication needs of the children, but also at their adaptive functioning, their autonomy, their affect, and their interaction with other people. I know that Caroline probably remembers that when we first started working in early intervention, we didn't have tools like this to help us figure out if the behavior that we were seeing with children was in fact a manifestation of the fact that the child was a 2-year-old, or if in fact this was some kind of actual social emotional delay. And so this tool does such a nice job of helping us define those specific behaviors that are in fact outside the margins, those behaviors that are in fact problematic that we need to take action on. The Ages and Stages Social Emotional also has a curriculum or a tool with it that you can use with parents to help them support their child's social emotional health. It's called the SEAM, SEAM. And it is a whole process of coaching and supporting families to improve their child's social emotional functioning. And so I'm a real fan of the Ages and Stages products, mainly because they've been used for many years now, and they've been used with a variety of populations of families, including the one that we're talking about here today. The next thing I want to talk just a minute or two about is childhood trauma and the signs of its impact on young children. In this, I'm trying to get to some of the issues that in terms of doing family assessment and trying to help families articulate what their needs are and what the needs of their children are. And so most of us now that work in early intervention are pretty familiar with the Adverse Child Experiences survey that is discussed a lot in early intervention. And you see on the left-hand column there, you see the different aspects of trauma that are evaluated in the ACEs survey. And one of the things that I have been most interested in over the last couple of years is how the impact of trauma on children relates to children's overall health and their overall emotional health and social emotional health. And so, what we see in children, there's a lot that's been written about the long term effects of having a certain ACEs score and how it affects our overall physical health, in terms of people who are more likely to get cancer or have heart disease, or those kinds of things. But there's perhaps less that's been said on the social emotional health, particularly of young children. And so, what we're starting to see is that those same variables that we're seeing in our children who have NAS are also presenting for children who have been exposed to childhood trauma. And so regulation issues with sleeping and eating, increased anxiety, aggression, and hyperactivity line up almost completely with the outcomes that we see for children who have NAS. And so I bring this to your attention, so that you understand, that for many of the children that we're working with who have NAS, they're also living in homes where any or one or more of these variables may be in existence. Family parents who have been imprisoned, divorce, domestic violence, substance use, and children are being exposed to those things, and then coming into those environments already with NAS. And so, the cumulative effect of this on children is something that we probably have not examined enough, and is something that I think that we do need to think about. And I'm very happy that next week you all are going to have a speaker that's going to talk about trauma-informed care, because I think as early intervention providers, this is something that we're all going to have to be dealing with. And I'm seeing I'm running almost out of time here, but I do want to plug one resource that I have found very helpful. This is a book. Some of you all may have heard of Nadine Burke Harris, who is now the Attorney General for the state of California. And it's from some of her early work, where she started seeing these patterns of behavior and development in the children that were coming to her clinic that was located in a very urban, low-income area of San Francisco, that she started to see some of these behavioral patterns that you see on this slide here. And so she started looking into the adverse child experience research, and started allowing that research to guide her intervention. And so not only in this book does she talk about the physiological components of childhood stress on children, but also she talks about some of the interventions that have proven to be helpful for children who are growing up and living with stress. And so when it comes to talking to families, and I hope to spend a little bit more time about this, all I can say is that we need to just we need to engage in effective communication strategies when we're interacting with families who are experiencing opiate abuse, and who are struggling to try to keep their families and their children together. And I think that many, many years ago, when Caroline and I started this, and the focus shifted from just interacting with children, but shifted toward interacting with families and interacting with other adults. We had to shift our thinking as early intervention providers and thinking about how do we engage families in conversations that are meaningful, that are open enough, so that families feel like that they are given the opportunity to articulate what their concerns are, what their resources are, and how they can support their children. And so I really encourage you to look at some of the work on how to be an effective communicator. And Christine, you asked about topics for future. I think this would be a wonderful topic for us to explore, because oftentimes in our interactions, unless we have a counseling degree, which many of you all may have, but oftentimes in our interactions with families, I think we instill guilt and judgment instead of support. And so trying to help early intervention providers learn how to do that, I think, is very important. And then finally, I just want to put a word in here. Look at all of the negative visual outcomes for children who have NAS, and this is really concerning to me, and primarily because I think that it's something that is oftentimes overlooked. And so I underlined why this is important, because a children's development, their visual impairment has a significant impact on children's overall development, because how do children learn? Children learn by exploring their environment. And if their development is, if their vision is impacted, then their exploration skills are going to be impacted, and that's going to impact their cognitive development. So let's not forget this aspect of development that is so important. And there's a word in here that I do want to just really point out: nystagmus, strabismus, and visual acuity refractive errors. Those are issues that you oftentimes will hear when you talk to an ophthalmologist. Less likely will you hear an ophthalmologist talk about cortical visual impairment. And so I put in here just some characteristics of cortical visual impairment. This is a processing problem for children, visual processing issue. It's the leading cause of visual impairment in all first world nations. And it's something that it may appear that the child is viewing and is looking and everything is intact, but in fact, they're getting a very distorted view about what's going on in their world. And so I encourage you to look at this a little bit longer. And if you notice that the children's, if something seems to be off, there are lots of really good resources out there on cortical visual impairment. The lead person, Charity Rowland, is kind of the lead person in cortical visual impairment, and you can find some wonderful resources from her. And Carolina, I've realized that I've gone on a little bit longer than I should have. There's some additional information that kind of sums up what I've been talking about the different aspects of development and how that impact is on children who have NAS. But I will turn it over to you now.
Jennifer, that is fantastic. This is information that we have been eager to dig into, and I really appreciate your sharing with us today. We're going to shift. We're going to make a smooth shift here to have Jason share a case study with us that will talk about these very things that you've been talking about. So Jason, I'm going to pull up these slides. And if you are there and ready, you may take it away.
Okay, sounds good. Again, my name's Jason. I'm the program director for the UK Pathways program, and we're going to present today about a mother that we've had in our program, and actually had one of our return mothers have had two pregnancies with us, and so we'll kind of get into some of the. So we're familiar with this mom pretty well, and her children. So just as a background, she's a 30-year-old pregnant female, currently in the Pathways care for, which is, we are a high-risk OB clinic that provides substance abuse treatment concurrently while they are getting their obstetrics needs met. They also, a majority of our moms are on medically assisted treatment in the form of buprenorphine products. And this mom fits that category. She's being treated for opioid use disorder as well as a stimulant use disorder, and is receiving buprenorphine. Our mother attends weekly sessions. During that time, she gets prenatal education that's geared towards reducing NAS and to improve infant outcomes. And she also gets weekly recovery meetings in the form of recovery groups, peer support, and individual counseling. She's tested positive during the second trimester. She was testing positive for stimulants. And of course, as is oftentimes the case in some of our moms, some are very straightforward about any kind of lapse or relapse or return to use. She was a little less forthcoming, but she did recognize that she had been around people who were using the substances that she tested positive for. And so we kind of used that as a discussion about setting some boundaries and keeping, prioritizing some of the steps that she has for her sobriety. She has a 1-year-old, again, that was born, that she was pregnant with through our program. She's currently pregnant now. She has a 4-year-old son who's, and both the 4-year-old and 1-year-old are in kinship care because after mom delivered her 1-year-old, about 6 months later, there was a return to use and DCBS got involved. And the children were placed in kinship care. Primary areas of concern for mom is helping her get stable in her recovery. There's concerns about her partner. What brought them together is they were both actively dealing and using drugs at the time that they got together. And that's kind of carried over into aspects of the relationship. Interesting enough, it's with his family, the father of the two current pregnancy and the most recent pregnancy. The father, it's his family that have now gotten supervision rights, as is oftentimes very common in CPS cases these days. They'll look for a family or kinship care to put in. But the issue there being is she no longer wants to be with him. But if she cuts off that relate because of some of his, because he's not sought treatment and because he still associates with people who are using drugs and she's trying to get sober. But if she cuts herself off from him, she cuts herself off from his family, then she cuts herself off from her children. And so that puts her in a really tough dilemma. So there's a piece of her that's staying very connected to him, despite wanting to, maybe remove herself from that relationship more. She did not complete high school. She had some learning difficulties and does receive a SSI because of that. So she gets supplemental income for disability. Others in the home use, so one of the things that has been an ongoing problem is that the father will often allow some of his family members to come and live with them, and they have historically have had drug problems, and this has actually put her sobriety at risk a few times in the past. And again, her concern is that if she leaves the father, that she would then jeopardize her contact with her children. For the children, for her pregnancy, there's a concern about keeping her safe during her pregnancy, about reducing any street drug use. There's the concern about her two boys that in the type of care that they're in. She has a lot of concerns about how well her two other boys, the 1 and 4-year-old, are being monitored. She feels like the kinship care is not very responsive to their needs, and at times neglectful. But this was the home that CPS recommended that they be placed in. And then in the process of getting kind of services that are getting involved, they've identified that there's a lot of hyperactivity in the preschooler. They have a difficult time. He's now that he is attending a preschool part of the day, he's had they've identified that he has a hard time managing his energy. She's noted that. Her mother, who's been active in their life, has also noted that he's a very difficult child at times to manage his energy. So there's been a concern about the hyperactivity, his aggression. He can be aggressive to his younger brother and is not easily redirected. They're considering Head Start enrollment. One of the tricky parts with that is during these COVID times, that most of what she's been offered is online instruction. And she says, how am I supposed to get them to sit in front of a TV? And during the, and I can't even get them to sit still. How am I supposed to get them to sit still and learn? So there's extra challenges that have come across recently, as opposed to maybe some of the in-home services or getting him to daycare that would be in person. The goals, mom wants to ultimately get custody of both her children and the baby that she's carrying. That's her goal. She wants to be nurturing. She wants them in a well-supervised environment, and would like to see the placement be changed to be with her mom, who has been instrumental in their lives, but because of some allegations that the father made about her mom allowing drug use to happen allowing her to use drugs in the home, she got kind of taken out of the running on that to be able to. But there's good history with her mom taking care of the boys. One of the goals is the preschool son is having difficulty with activities, aggression, and redirection. She would like to get that addressed and get him school ready. The barriers, obviously, there's some concern about mom's continued drug use during this pregnancy, and as that kind of jeopardizes some of her goals. There's the relationship with the boy's father, this pregnancy and another pregnancy. She has to live with him, and he has relatives that are using, and the father has been abusive and has dealt drugs in the past, and so they don't have a great history together in some regards. Mom also feels like she can't leave the father without losing contact of her children. Current kinship care, she's concerned about the well-being of her children. She feels like it's not adequate, and at times that they're being left alone with not a lot of supervision. Strengths. She's very active in her treatment. She's coming to group and shows up every week. She's willing to seek advice and help from other group members and from staff. She's very forthcoming with DCBS. She likes to she'll give them information. She's not trying to duck and dodge them, but willing to work with them. She does have a steady income in the form of a disability check. She does want custody of her children. This is a very high priority. She's willing to go above and beyond to try to make that happen. She's the maternal grandmother. Her mom has been very active in her life, has provided a stable environment for her children in the past. Her sons are very healthy and energetic. They have a lot of energy and are moving around and appear to have a very good bond with both their mom and their maternal grandmother. They definitely seem to acknowledge their presence and seem very comfortable in their care. So I think that's it.
That is it. Jason, thank you. That gives us lots to work on in our breakout groups. That's a wonderful story, relates to what Jennifer shared with us. So thank you very much for sharing this case.
No problem.
You all may take a picture of this slide if you wish. We're going to go to breakout groups now. We basically recommend that you talk about strengths that we hear about for the children and for the family, and then talk about some strategies that you suggest based on your experiences. What strategies might you recommend to this family, and any resources that you have that relate to this situation. So strengths, strategies, and resources, and any other comments you want to add. We will take about 15 minutes for our breakout groups. Brandon, if you want to bring us back at about 3:12, he'll give you all a 1 and 2 minute warning, I believe, and then we'll come back as a whole and we'll share some of the strategies that we have shared together, and we'll have Jennifer give her input to what we come up with. So we will move you into breakout groups. Be patient as we move you, and we'll see you back here about 3:12. Welcome back as you all come back. I'm going to share my screen. Actually, I'm not going to share my screen because I want to be able to see you all, but let me flip to the next. Yeah, let's not do that. So as you all come back, I'm going to ask, our time went really fast and wonderfully, and I'm just going to ask you all to share out some of the results that you found, and I'll just ask for a volunteer who would like to share some of the strengths you saw, some of the strategies.
I don't mind discussing what our group came up with.
All right.
Okay, so we said that her strength, the mom's strength seems to be that she has motivation, and also that her mom seems to want the kids. But then there's also this undercurrent of uncertainty because she had a relapse with this pregnancy. And also, you know, the question is she going to continue to be stable enough to be a good home for the children? Is she going to be able to provide that once she gets away from the father of the baby? I mean, is she using him as an excuse for some of her problems, or are some of her problems really dependent on her relationship with him? And then the father of the baby's mom is not currently the best caregiver, and there's not a lot of good relationship between them, or communication between them. Some of the strategies that our group came up with was, actually we had a lot of them. The Head Start was suggested for the 4-year-old, First Steps for the 1-year-old, a referral there, Hands for the new baby. Karen also mentioned the START program, so we had some talk about that. Because Marie was saying that had to be started like right at birth, like right from the get-go, so that would have to be started right away. Denise, who's an OT, also suggested maybe OT program at Head Start for sensory issues. Christy suggested maybe a daycare setting for the 4-year-old just to have some other children to interact with. Wendy suggested play therapy. And then some therapy was suggested maybe for the mom and the father of the baby, mom and the current caregiver, father of baby's mom, and her mom. And then also some education of both parents in terms of like maybe some nurturing parenting classes. And that would have to be probably court mandated by DCBS. So those are, yeah.
Yeah, that's great, Jody. Thank you so much for all
You're
of you.
welcome.
If I can get one more group to volunteer, then we're going to get some feedback from Jennifer. Is there one other volunteer who would share with us what you discussed?
Okay, I'll hop in there.
Thanks, Joy.
All right, so some of the child's and family strengths is that mom wants to get help. She has a good relationship with her mom. She is involved in her recovery, and she wants to regain custody of her children. She is active and going to those weekly meetings. She's aware of the challenges with her partner, and trying to work on getting out or working through some of those issues. She has self-awareness about what's going on around her. She is determined and persistent, and she asks for help. So I echo a lot of what has already been said about the different strategies. We talked about the HANDS program. the START program, getting an assessment for the 4-year-old for sensory processing, getting resources for the grandparents. Talked about referrals to the community mental health center, PCIT for grandparents to help them out, and also an organization called Voices of Hope, and that will offer some peer support and coaching, ways to build relationships more within the community, and with her peers to understand that, you know, she's not alone.
Fabulous. Thank you. That's similar to some of the things that we shared in our group. And as we turn it over to Jennifer, I would just ask one more time for all of you to consider sending us a case study related to trauma-based intervention for families with young children. Please give this serious consideration and send a case study suggestion to me and Christine. Any day this week would be lovely. We would much rather talk about a case that you all would like feedback on than anything else. So please consider sending us a case study for next Tuesday. And Jennifer, do you want to give us some feedback, kind of wrap up some of the strategies that we talked about? And you are muted still.
I think that, you know, just a couple of things that I want to just remind you all about based on what I said. First of all, you know, we're looking at a population of children who have, you know, what I would consider to be kind of layers of risk factors here. You know, in addition to having NAS, they also are oftentimes children who are living in poverty, which is a whole set of risk factors itself, and also children that are experiencing a lot of child trauma. And so, I would encourage, I'm not familiar with all of your programs, but any of you all that are working, you know, rather indirectly with children, I would really encourage you all to consider trying to monitor children's development in some way, whether it's using the ASQ or whatever kind of developmental screener you want to use, because this is not something that takes a tremendous amount of time. But one of the things that we know for sure is that early intervention works. And so the earlier that we can get these children who are so vulnerable into the programs that we know are going to make a difference, the better off that they're going to be. The second part of that is just to remember, is just a reminder about the interrelatedness of development, and that a lot of times the things that are the most salient, like behavior challenges, are the things that families are going to be most concerned about, and they're going to articulate them the most. But remember, or don't forget, the underlying factors that may be causing some of those behavioral challenges. And, you know, look at the cognitive delays, look at the language delays, look at the, you know, the difficulties with, self-regulation and some of those issues. Also, we talked a lot about programs in our group, and I think just to remember that there are, for a child like the child in this case study, we're talking about a child that's probably going to qualify for one or more different types of programs. The sad thing is that, as someone mentioned, a lot of these programs are only offered right now online, which is a travesty. But as soon as possible, a child like this could benefit, like this 4-year-old could benefit from going into a center-based program where they're getting some structure, hopefully. They're getting some consistency in caregiving. They're getting their social emotional needs met. That said, not all center-based programs are the same. Even in Head Start, which there are many, many good Head Starts out there, but they're not all necessarily good. And so just making sure that we want to put these children in high quality. If it's a child care program, there's a wide range of quality in child care. And so trying to get a child that is this vulnerable into a high quality program, I think, would be very important. And then finally, so many of the programs that we've talked about have some kind of component to it where we're trying to support parenting, support parents to be better parents, and I would just suggest that all of you all look at the coaching literature that's out there. It actually comes out of Early Intervention by Rush and Sheldon, that talks about how to be a good support system for families who have children with developmental problems, and how to coach them in such a way that their behavior changes and therefore their child's development improves. And so I think those were the three things that I just wanted to.
And I would just add, we had a great comment in the chat. One of our participants works for VIPS and First Steps, and she reminded us that a characteristic to watch for children who might have cortical vision impairment is a lack of eye contact.
Yes.
That reinforces what Jennifer said about vision. We have time. If anyone wants to raise a question or a discussion point, you can unmute or raise your hand and we'll call on you. Probably better if you unmute because I can't see all the faces at one time. Questions or comments?
I'd like to say that I'm in the Facebook group that apparently Carolyn mentioned, and I love it. It has been an awesome source of information. And I noted in the chat that it's very non-blaming because there's biological parents, there's foster, there's adoptive, there's professionals, and it's just a really cool supportive network.
Thank you, Risa. It's an exciting group for sure. Very informative.
Mm-hmm.
I want to add a comment on the eye contact, just to be really, as folks are looking at that, to be careful about is when the infant is really young and they've had NAS, they will gaze avert a lot more than an infant who has not had NAS, really early on, because they get overstimulated so easy. So you want to pay really close attention to what that's about and how long that it's lasting, because obviously as they get out of that newborn stage, we would expect, even with NAS, that they're able to maintain a mutual gaze. But when they're really young, just as any newborn baby, when they're overstimulated, they're going to gaze avert, and infants with NAS get overstimulated very, very easily. So we want to always, really think about, their age, what we're seeing, are they making any eye contact at all? Just so we're also keeping both of those lenses on when we're looking at him.
Thank you, Sharon. We have time for more comments and questions.
I wanted to share something. This is Elizabeth.
Elizabeth.
To echo what Jennifer was saying about, it's really too bad that programs aren't in person right now for thinking about this 4-year-old. But there are programs that are being offered virtually, right? So in our group, we talked about that hand sessions are still happening, telehealth. First Steps is still telehealth. Someone else in our group mentioned about family therapy. And so I'm just thinking that a lot of those strategies are going to overlap. And so things that a parent may hear from hands may overlap with First Steps, may overlap with treatment that they're going through. And so that can indirectly help the 4-year-old as well, because these things are just going to layer on top of each other.
Good point. Thank you, Elizabeth. Someone else? Comments, questions? It's nice to get to have this time to hear from the whole group all together.
Really appreciated in the presentation when she talked about the family piece and, to build engagement, that it's not, it's focused on the child, but it's more focused on the family as a resource for change. And to really look at a family's strengths and capabilities and resiliency. And those portions are emphasized as well, to help build engagement and keep families in service, and creating that buy-in. So I really appreciated that part of the presentation too. So just wanted to say that.
We used to talk in early intervention. I think this may be a taboo word now, but I think it is appropriate for this context. We talked about family empowerment, and I think, for so many of these families who have grown up and been part of chronic stress themselves, in Burke's book, she talks about generational toxic stress. And so in those situations, their, their capacity to feel like that they can make a change in the lives of their child has sometimes diminished. And so if we can join them, as partners, and help empower them to feel like they can make a change, then it's more likely to happen.
It's a real mind shift for us working with the family, where the family component in this condition is just as important as the child component. It's a shift for us. We've got time for one more comment before we go to Emily to close us out.
I wanted to touch on something Christy Jones had mentioned before, that NAS is not an established risk condition for First Steps. However, anyone can refer their own child or a child they're familiar with to First Steps at any age from birth to 3. So if you're a professional who works with moms and families whose children have NAS, encouraging them to make that referral on their own. Again, it's an opportunity for empowerment in those families as well. It's a simple, it can be a long process, but it's a simple process, and there's a lot of great folks that are available to help families get through the assessment component. And just because it's not an established risk, those concerns are there at birth, and so they may qualify and be able to start receiving services right away. And right now they are teletherapy, but again, we're all available to those families. So I hope that we'll all keep that in mind and keep advocating that program to families too, because it's a huge help to families who need it.
Kelly, thank you for reminding us of that. That's wonderful. Now I'm going to share my screen and turn it over to Emily to finish us out. And I really appreciate all of the discussion today, and I look forward to seeing all of you in a week. Emily, it's all yours.
All right, so this is our reminder about the evaluations. And last week I said I was going to send them out within an hour, but it got a little bit delayed. So again, this week I will try again to send them out before 5 o'clock today. We really appreciate your feedback, and we adjust based on your feedback. So it's very important to us. We want to make this as relevant and helpful to you all as possible. So if you have any ideas or thoughts or questions, criticisms, please send them to us. After each session, there's a drawing. So Amy Moore won for the last session. And for participants that show up to every session and fill out every evaluation, you will receive your choice of a book out of 4 choices, and we will have those choices for you very soon. We're still narrowing down. There's so many great book options. And if you need any kind of CEU or certificate of attendance, Brandon is the person that you would reach out to, but we do have those available. And we have ECE TRIS clock hours, and we have all the information if you want to apply for the CEU on your own. So any questions, please just reach out to us and we can help you navigate that. A reminder that our next session is next week, not 2 weeks from now. So we will see you on October 27th. And we will talk about trauma-informed interventions. Again, please, if you have a case study or an idea, please send it our way. We would love to talk about that. Here are our email addresses if you need to contact us. And I think that's it. Please keep an eye out for the evaluation. If you didn't get it, please reach out to me and I will send it to you directly. So thank you so much for being here. We really appreciate the interaction and participation, and we look forward to seeing you next week.
Thanks, everybody.
Thank you.
Thank you.
Thanks, Jennifer.
Welcome. I enjoyed it.
Thanks. Thank you, Jason.
Thank you.
Great team.